time. The next lecture is by Professor Mojgan Hodaie on imaging the cranial nerves. Moji.
Thank you, Chris. Thank you so much for asking me to present. Is it the green button? Okay, a little bit of changing gears. Hang on, here we go. We've talked about neurovascular compression for quite a bit already today, and I want to ask you to keep this in mind, because when we look at an MR such as this, we've been accustomed to, whenever we look at it, to immediately think of the vessel compressing the nerve. And yet we know that the trigeminal nerve itself is not associated with one syndrome alone. There's a number of clinical features, there's a number of clinical presentations that we see. Essentially, I think that we have a bit of a bias when we think of trigeminal neuralgia, because our own understanding of trigeminal neuralgia is really something that is shaping how we study this condition. Initially, if you go back historically to way before Janetta, there was resection of the ganglion, ablation, extirpation, avulsion, things like that. And eventually decompression was proposed as a solution because it's shifted our understanding and our focus to the source of pain, namely the root entry zone. But in addition to that, studying nerve-related changes has been an ongoing problem. Imaging of the nerve itself is difficult. We really can't record from it properly, like we do, for instance, for Parkinson's and so on. And the most common forms of the study of pain are very cumbersome when we have patients with trigeminal neuralgia. So we know already that neurovascular compression does not fully explain the concept of pain, and therefore I think that there needs to be a change in our approach. We've referred to this before. About 40% of patients with trigeminal neuralgia, in fact, show bilateral compression. The pain is overwhelmingly unilateral. About 20% of healthy subjects have neurovascular compression and no pain. Not every patient with trigeminal neuralgia shows neurovascular conflict, and about, I would say, 10 to 25%, depending on the duration of assessment after surgery, really don't respond well to treatment. And we've seen this allusion to this paper before in 2009, and it's important as well that this patient also mentions this concept of bilateral, which when I first read the paper, I said, oh, curious, and I put that to the side in my mind. But I think this is something that we need to think about. And it's really in consideration of all the points that I've mentioned to you so far that about, I would say, over 10 years ago now, we decided to change our approach and focus on visualizing the nerve using diffusion tensor imaging, and shifting this idea of perpetually chasing the blood vessel to now looking at the nerve at diffusion tensor imaging based on fractional anisotropy, and really constructing images of the cranial nerves the same way we construct white matter tracts elsewhere. And again, moving from imaging such as this, conventional imaging showing neurovascular compression, to now looking at the nerves themselves, in their tracts, in their microstructure, and importantly, being able to gather metrics from these microstructures and explaining those. So we can do that for obviously the brain and the trigeminal nerve that I'll talk to, and other cranial nerves, but really for the sake of time, I'm focusing only on the trigeminal nerve. And my interest is to really move from diagrams such as the top right that you see to now accurately demonstrating the position of the nerves and drawing metrics from these. And these diffusivity metrics, as you know, can correlate with either myelin or axonal changes. They allow us to understand disease entities, and importantly, they can serve as prediction models as well. So we can, for instance, use diffusion tensor imaging to look at the nerves themselves. We did that in the top study in 2014, and showed that indeed the root tension zone of patients with trigeminal neuralgia is different than healthy controls. And importantly, here we have an emerging theme that in this study also we showed that the changes are bilateral, although much more pronounced at the affected side compared with unaffected side. So we can image the root entry zone, we can compare them with controls, and we can also image the cisternal segment. So rather than just measuring from the voxel, construct the whole of the cisternal segment and use that for serial imaging pre and post gamma knife radiosurgery, for instance. In this case, you can see in the in the bottom left panel, the top nerves are prior to gamma knife radiosurgery and the bottom nerves are after gamma knife radiosurgery. But of course, this is just the cistern that we're talking about. So that's only one component of the trigeminal nerve. What we are interested in is what happens also at the level of the brainstem. So I'll talk about this a little bit. And importantly, I'll talk as well about multiple sclerosis related trigeminal neuralgia. This is actually very important because we know that these patients can have a very similar presentation clinically to patients that have classical trigeminal neuralgia. But their pain origin, if we can name it that, is entirely different. So we wanted to know whether diffusion tensor imaging is actually able to pinpoint the difference between these two patients that have classical trigeminal neuralgia versus MS-related trigeminal neuralgia. And indeed we can. So for this, we modified our technique to be able to actually measure and image the fibers of the trigeminal nerve within the brainstem. So this is area of high crossing fibers. And we saw that in patients that have multiple sclerosis, we in fact see diffusivity metrics that are abnormal in the perilesional segments of the trigeminal nerve. And these abnormalities distinguish patients that have MS from classical trigeminal neuralgia who don't show abnormalities within the brainstem per se, and also point to myelin-related changes. So when we look at their diffusivities, is primarily radial diffusivity and mean diffusivity that point to myelin and also to inflammation, and not so much axial diffusivity that would point at axons. Axial diffusivity, in fact, is unchanged. But let's look again at patients with multiple sclerosis-related trigeminal neuralgia. When we image their plaques, it's quite routine that, in fact, they have bilateral plaques. But also their pain is, again, most commonly, not exclusively, but most commonly unilateral. So what is it, what's going on? First of all, we can image the nerve and the relationship with these plaques. But is it that some plaques are active and others are not? And what is it that we should do now? Should we, for instance, now start imaging myelin? And I think this really is a door that leads to another door. So imaging these nerves and looking at these plaques, in fact, has led us to another way of visualizing myelin and trying to understand what results in demyelination, remyelination, or dysmyelination. So in a sense, a way of estimating the degree of demyelination in vivo. And in this way, by looking at this T1 to T2 ratio, we now are able to develop an estimate of how likely it is that a plaque is active versus one that is not active. Another way in which we've used imaging of the nerve is looking at the effect of radiation on the nerve when patients have gamma knife radiosurgery. And for this, we look exactly at the target of radiation. And we see that when looking at this target, the patients that are going to be long-term responders have significant drop in fractional anisotropy, representing, again, changes at the level of the nerve that are perceptible and can be distinguished from those that are going to be non-responders. So this is at an earlier time point after treatment compared to just following these patients serially based on clinical grounds alone. But importantly, can we use this data to develop some level of objectivity when we assess patients? And where does this objectivity lie? Again, I point to the cisternal segment, the root entry zone, and the pontine segment of the nerve. And I'll ask you again to hold on to this information as I as I put things together in a few slides from now. So what we did is we took the MRIs of a subset of patients and looked at their pre-treatment diffusivity changes in all three segments of the nerve, so cistern, root entry zone, and the pontine segment. And then we moved forward to 1 year after treatment to see whether their pre-treatment MRI could predict their clinical outcomes a year after. And in fact, it can. For patients that are going to be responders, what we see is that the diffusivity changes are primarily in the cisternal segment. And the ones that are going to be non-responders, often they show changes within the pontine segment or root entry zone, suggesting that in fact what happens is that the pain appears to be, or not the pain, but the microstructural changes appear to now be centralized when the patients are going to be non-responders. So hold on to that item, and then let's add it to this, and that is the finding of a group of patients that we described with this new syndrome called solitary pontine lesion. And in these patients, we observed that they have this unique punched out lesion within the pons. So these patients don't have multiple sclerosis. I'll show you, for instance, the MRI of one of these patients that does not exhibit any of the McDonald criteria. There's no level of evidence of atrophy. The brain looks good and healthy, save for this, boom, punched out lesion in the pons that results in the presentation of what turns out otherwise to be entirely classical trigeminal neuralgia. This lesion is seen better in T1. You can see it in T2, but not so strongly. And again, it's quite different. So it's punched out in the syndrome, perfectly fine in patients with classical trigeminal neuralgia. And of course, in MS, we have multiple lesions, and we, of course, have to have the criteria of number of lesions as well as progression with time. And none of these are met by this condition. So we termed this a new condition called trigeminal neuralgia associated with single pontine lesion. And we looked at its clinical and neuroimaging characteristics. And when we map these lesions using advanced brain imaging, the lesions map to the trigeminal fibers within the brainstem. And when we look at the lesion itself, as well as a mirror site contralaterally, as well as patients with multiple sclerosis, we see that there are key differences, particularly when we look at MS. These lesions don't quite correspond to what we see in patients with multiple sclerosis, suggesting that the microstructure of this lesion is very different than just a sclerotic plaque in MS. We don't know what it is, but it's much more punched out, and the patients really behave slightly differently as well. And then we come to the understanding of, if we see these changes within the brainstem, to what degree are they able to predict? So I'm not going to talk about the role of the brain cortex or the sort of neocortex in this matter. I believe Tejas will be discussing this a bit tomorrow. But if we look at this chart here, we see that patients with classical trigeminal neuralgia are obviously the ones that are going to respond the best, followed by MS, followed by these patients with single pontine lesion. And in fact, the number is such that we have roughly 85% of patients with classical trigeminal neuralgia showing good response to treatment. About 70% of the treatment may not necessarily be the same. Patients with MS showing good response to treatment, and guess only 5% of patients with single pontine lesion end up showing long-term good response to treatment. Within this group, if you recall, we have a group that is non-responders that show more centralized changes, again suggesting that there are microstructural and also macrostructural abnormalities, and these correlate with likelihood of response to surgery. So we can now start slowly putting a picture together that suggests that in fact the nerve is very different in patients that are going to respond well to treatment, in what we presume is classical trigeminal neuralgia, but then the patients end up being non-responders. These are not necessarily the same entities. And then this follows again with This follows again with other type of structural lesions that are now much more obvious, such as MS, and then this group of patients. The next stage in the game for us is not to image patients individually, such as this, and do 1, and then 2, and then 3, and then 4, but instead move to group imaging, such as in this case where we stacked, I believe this is a stack of 39 patients that are all imaged together, and we're able to do group analysis and using Gaussian process classification, really walk all through the nerve at the level of the root entry zone, along its decussation and beyond, and be able to do group-wise along the tract statistics to understand what happens in trigeminal neuralgia, what happens in controls, what happens in patients with multiple sclerosis, and slowly gain a better picture that, I have to say, minimizes the role of the blood vessel and focuses entirely on what the trigeminal nerve and its fibers and connections are doing, and how these contribute to our understanding of both the disease entity itself, as well as who responds to treatment. So with that, I thank you very much. I'm not sure if there's time for questions, but we'll leave it there. Thank you.
May I ask one question? What do you think of the clinically isolated syndrome? So, you know, I see a young girl and I follow, or, you know, treat her trigeminal neuralgia, and 25 years later, she's got MS.
So that's very interesting. I've only seen one patient like that, that presented with trigeminal neuralgia, and afterwards, years after, not so much 25, was diagnosed with MS. I find that to be quite rare, in my experience at least. I find that most patients with MS, in fact, present with MS and develop trigeminal neuralgia as a consequence of the MS, and not backwards. I'm not sure what the experience is overall. Kim?
Can please use your microphone? Yeah, so the people online, there's about 30 people online.
Yeah, Kim Birchall, just a question about any, I didn't hear any sub-analysis by gender or age in your tractography, did you?
The sub-analysis is done at the level of the brain, and not at the level of the trigeminal nerve. At the level of the brain, all the studies that we've done, so that includes neocortex, that includes hippocampus, and the recent study that we published on accelerated brain aging patients with trigeminal neuralgia, all of them are very clearly distinguishing females from males. And we see that the effect is, in general, driven by women.
Okay, maybe I'm looking at tractography just of the nerve. You haven't done a sub-analysis of younger females based on tractography. Is that
We
correct?
have not, but
Okay.
that, I think, appears to be the flavor of the afternoon. So it might there might be some
Might be
interest in that.
worthwhile.
Yeah.
But you have, and one more thing that I understand, you have looked at cortical thickness